that okay?
Yes, sir.
Okay. Now I'm going to put a timer for you. As I told you, this one is critical care stations. I'm not going to put you any station or scenario, but we'll discuss later. Just start with post-operative anastomotic leak case, a clinical examination. Okay, the time start from now.
Okay. Hello, I'm Dr. Iqbal, one of the exam candidates here. May I know your name and age, please?
Yes, doctor. I'm John, 60 years.
Nice to meet you, Mr. John. Are you in pain or any distress?
Yes, doctor. I
Right
have
now?
some breathing difficulties, as well as I have some pain in my tummy.
I'm really sorry for that. Do you need anything, any medications, any painkiller, or is there anything I can ease you?
Not at this moment. I just some breathing difficulties, some tenderness, maybe in my tummy.
Okay. Thank you very much. And I'm really sorry to hear that. Today I have been told to examine your tummy. To do that, I need you to do some looking, feeling, and do some listening over your tummy, as well as do some relevant general examinations. Are you okay with that?
Okay, doctor.
To do this, I need you to remove your gown to expose your chest and tummy. Is that okay?
Yes, doctor.
Do you need any chaperone?
No.
Okay. Let me start with your just having having a palpation over your tummy. Where is the pain right now?
All over the tummy.
Okay, I'll just be very gentle with you, and if you feel any discomfort, please let me know. At first, I will have a superficial
Doctor, it's so
palpation over the
painful.
right iliac fossa.
So painful, doctor. I can't
Okay.
remember this one.
I'm really sorry. I'm really sorry. And do you need any medications?
No, absolutely not, doctor.
Okay. As the patient is critically ill and the patient is post-operative condition, I would like to start the procedure with care of critically ill surgical patients. At first, I will look for the airway. As the patient is talking to me clearly, I believe the airway is patent, and I will give I would like to give the patient 12 to 15 liter of humidified oxygen with a non-rebreathable mask. And then I'd like to proceed for the breathing station. At first, I'll have a look for the anemia, cyanosis, central cyanosis. Can you please stick out your tongue?
Yes,
And
doctor.
look for the lower palpebral conjunctiva. And can you please look to your left side so that I can look at his veins, neck veins? And can you please look to your right side as well, to the right-sided vein? And and then I'd like to inspect the chest from the side by kneeling down on my knees, and then from the end of the bed, from the foot end of the patient, and inspect the chest for the rate, respiratory rate, rhythm, respiratory pattern, and look for any scar mark, any thoracotomy or thoracostomy mark, or any other abnormalities. And then I would like to do the palpation. At first, I look for the airway, trachea. I'd like to feel your air windpipe. That will be little discomfortable, but will not cause you any pain. I'd like to feel the trachea is shifted to right or left, and then I'd like to palpate the chest expansibility at the apex of the lung, and the mid portion in the mid nipple line, and then in the lower portion of the chest. By asking the patient, please take deep breath in and take deep breath out. Okay, and then I would like to do the percussion. I'm gonna do some tapping over your chest. That will not cause you any pain. If you feel any discomfort, please let me know. And I'd like to percuss over the chest from the first first space, intercostal space above the clavicle, and then the clavicle, and then below up to the lower chest, in the mid clavicular line and in the mid axillary line. Both side, I will compare both of the sides, and then I'd like to move to the auscultation part. Now I'm going to listen to your chest. Please take deep breath in and out. Listen to the chest in the all zone, from front and from the axillary portion as well, and compare both sides. And then I'd like to look for the vocal resonance. Can you please say 99 each time I touch your chest with this stethoscope? Can you say 99, and I will check all the zones same equally. And then I'd like to move to the circulation part. Look for the capillary refill time. Look for pulse, blood pressure, and then I'd like to listen to the heart. Now I'm going to listen to your heart, as well as I'd like to put my finger in the carotid pulse while I'm listening to the heart sounds. And as the patient will be hypotensive and tachycardiac, and I'd like to
Your time finished.
give the
Your
patient
time
2
finished.
IV.
Mr. Iqbal, your time finished, but you continue
Sir.
because this is not the real exam. Continue, please.
Okay, sir. Okay. So I would like to give the patient 2 large bore IV cannula and give IV crystalloid fluids running, and 20 ml per kg as the patient is hypotensive. And then I'd like to take blood for full blood count, urea and electrolyte, liver function test, blood grouping and cross matching, and make 6 unit of cross matched blood, as well as I'd like to do ABG, serum lactate level. I'd like to do ECG and chest X-ray, and give the patient a pulse oximeter to monitor his saturation and pulse, and I'd like to give an indwelling catheter to monitor urine output as well. And then I'd like to go to his leg to see whether there is any calf tenderness. Do you have any pain in your calf?
No, doctor.
I'm going to squeeze over your calf. That will be very gentle. Please let me know if you feel any pain. And I will squeeze the right and left leg, and also see for the capillary fill time in the nail bed, and look for the edema. And then I would like to move to the disability point. As the patient is talking to me, and seems like he is well alert. So patient is alert, I think. And then I want to do the exposure of the patient to see the wound. And then I would like to see the charts, early warning sign chart, blood pressure, oxygen saturation, pulse, temperature, and I would like to
What chart do you
see
want?
the lab reports as well.
What types of chart?
The early warning sign chart.
Okay, and anything?
The chart that and lab reports, especially for
Lab
the
reports.
full blood count,
Full blood
ECG.
count. Okay, full blood count here. WBC count raised.
Yes, sir.
And what do you want?
Do you listen to me, sir?
Yeah,
and
I can
ECG.
listen.
I'd like to do ECG.
ECG, okay.
And ABG.
ABG,
urea
okay.
and
Then
ABG,
summarize your case, please. You
serum
finish your
lactate.
examination?
Yes, sir.
Okay. Then summarize your case, please.
I examined this gentleman presented with shortness of breathing, as well as severe abdominal pain, and right shoulder deep pain as well. As the patient was critically ill, I started to manage the patient according to care of critically ill surgical patients. At first, the patient's airway seems patent, so I gave the patient 12 to 15 liter of oxygen.
No, don't repeat
And
all
then
these
I moved
things.
to the.
You just summarize. I told you summarize your
Okay.
case. Don't repeat all
Okay.
the examination. Okay. Then go for How do you investigate this patient?
I'd like to investigate the patient with a full blood, all the routine investigations, including full blood count, CRP, urea and electrolytes, ABG, liver function test, blood grouping and cross matching, and ECG, chest X-ray, ultrasonogram of the abdomen and abdominal X-ray, and gastrography in CT enema to see if there is any anastomotic leak. And I'd like to do CT pulmonary angiogram to see whether there is any pulmonary embolism.
Okay, how do you manage this case?
As the patient is critically ill, this needs urgent laparotomy, and I'd like to proceed with the Hartmann's procedure with good peritoneal toileting and drainage.
Okay, thank you so much for your participation with this mock. Let me discuss with this case. Okay, so always remember, all CrISP case are post-operative. Either it may be due to hip replacement, knee replacement, or any long bone fracture after operation. It may come for pulmonary embolism. And for anastomotic leak, it's post-operative anastomotic leak. Okay, so it's a clinical scenario. Don't mix with diverticulitis or any other acute abdominal condition. Okay. The second thing is when you finish your scenario and then enter to the station, okay, the first thing is wash hand, introduce yourself, obviously these things. As you are going to do abdominal examination, then you should start with peripheral stigmata of abdominal examination, that is hand examination, clubbing, checking pulse, and then go to neck, then lymph node, checking eyes, and rapidly go to abdomen when he's getting pain and you see that he's not feeling better, and then tell the examiner that I'm going to proceed with CrISP protocol, that is A to E protocol, A, B, C, D, E, and then you start with A. So remember, when you start with A, that is EROA. So when we elaborately discuss EROA, that is look, listen, feel. But you can't do everything within 6 minutes. So that's why if the patient is talking, that means EROA is patent. And then go for breathing. So in breathing, starting of breathing, if patient is not comfortable, if you have some difficulty with breathing, check his saturation level. Sometimes they put marks with 2-liter oxygen, but saturation is dropping below 90. So, and then you have to correct the marks and put 15-liter, 12 to 15-liter oxygen non-rebreathing marks and attached pulse oximeter. This part is in breathing portion. It's not after C or after investigation. So when you start these things, you should start with these things. I mean, in EROA is patent or not, just check this. If he's talking, his EROA is patent. Basically, EROA is patent, but in a common scenario. And in breathing, when you start breathing, always remember, start with oxygenation. If he is comfortable with oxygen, that's okay, that's fine. But if his saturation is dropping, you have to put the marks and say, are you comfortable with this? And if you say comfortable, yes, you can proceed. Should I proceed? And then you can start. And in B part, the bedside examination. So always remember, when you are doing the B, so in B, the first thing is respiratory rate. You have to count this. And any thoracotomy, sternotomy, you mentioned all these things. I just focus on some important things. That is here, bedside investigation. In B portion, bedside investigation is ABG, arterial blood gas analysis, and chest X-ray. Okay, so in B part, when you finish B part, I'd like to do one ABG as well as chest X-ray, bedside chest X-ray, bedside ABG. That's finished for B. So in B, position of the trachea, as well as chest expansion, percussion, auscultation, any thoracotomy, sternotomy, scar, as well as checking heart sound is also important in this portion. And then go for C. So in C, when you start with C, so start with capillary refill time, a pulse, and then go for blood pressure. You never check blood pressure, you should not go for blood pressure checking. When you are going to check blood pressure, you will lose your time. So that's why it's already mentioned in observation chart and if any chart available there. So you should not proceed with that. And then when you finish this part, as the patient is hypotensive, then you should say, I'd like to introduce wide bore cannula and take the blood for full blood count, electrolyte, LFT, CRP, blood grouping, cross-matching, and related investigation. And I'd like to start crystalloid. So always remember, is a bolus amount of crystalloid calculation. So just go for 250 ml for 15 minutes, 500 ml for 30 minutes, and 1 liter for 1 hour. So basically what we do, 500 ml for 30 minutes, that's okay. And monitor the patient hourly. Okay, and monitor the patient hourly. So there's the C, but here bedside investigation.
Please repeat it again.
Sorry?
Sir, can you repeat it again?
Okay, in C, so start with capillary refill time, pulse, as well as if you want to check dehydration, you can check this, but you don't have enough time. But what you have to do, I'd like to open one wide bore cannula and collect blood for full blood count, electrolyte, LFT, CRP, blood culture, lactate. Okay, because it's an infective case, anastomotic leak case, so you have to send lactate blood culture. Don't forget lactate blood culture in this case. And then what we have to do, then introduction of fluid. So for introduction of fluid, you have to introduce crystalloid, bolus crystalloid, 500 ml for 30 minutes, and we'll monitor the patient hourly. Okay. And the bedside examination investigation for this case is ECG. Okay, so this one is the bedside investigation for C portion C. Okay, and then come to D. So are you sure you don't have any urinary catheter? You are going to introduce urinary catheter. Check first. Okay. Hello. Can you hear me?
I have to check first. Yes.
You have to check first in D portion, the exposure portion. It's basically in E portion. So in D portion, basically you have to check is alert or not and people. Okay. And then E portion, exposure, you need to expose 3 parts. Remember always, you need to expose 3 parts. First part is bandage area, the abdominal bandage area, as it is the post-operative anastomotic leak. So there should be a bandage over the abdomen or tummy. So you have to ask that, I would like to remove this bandage to check if anything going wrong or not, or condition of the bandage you have to describe in summarization. So I found the bandage is dry, okay, or gauze is dry. Okay, so the first thing is this one, and the second thing is you have to check the urinary catheter. Is there any urinary catheter present or not? If not, you have to mention that I'd like to introduce one indwelling catheter for this patient and monitor the urinary output as well. Okay. And then the next point is checking teats. The patient have teats or not in his or her legs. Okay. And don't compress the legs. Sometimes it's so painful. You just touch the patient leg and observe his face or eyes if there is any tenderness or not. Okay. And first inspect the leg if the leg is swollen or not, and any color changes of the legs, and then touch the legs. So there's the rules for leg checking. These are the things, but before and then go for observation chart and drug chart. So in observation chart, you'll find WBC count raised, temperature raised, and then you'll find some blood pressure decrease, temperature increase, total count increase, and heart rate obviously increase. Okay, these 4 points you have to check for at least. And the next thing is to differentiate. Can you please mute? Okay, thank you. The next point is you have to check that is drug chart. Don't miss the drug chart. So the patient may be heparin or warfarin or any other medication, or patient are getting any antibiotic or not. So you have to check the drug chart as well. Did you check that? No. Okay. And then mention to complete my examination, I would like to do complete abdominal examination as well as digital rectal examination and discuss with MDT. Okay. So these are the things, as well as if you would like to mention that, I'd like to check genitalia and other things. You also mentioned that things. So these are the complete examination A to E, and you have to finish within 6 minutes, but it's really difficult to finish within 6 minutes. That's why practice is really important, and try to practice with time limit so that you can finish within 6 minutes appropriately. Then you'll get maximum mark in this station, and then you have to summarize this station after 6 minutes. So for summarization, just tell the positive point and 1 or 2 important negative point. Don't go elaborate description, otherwise you miss the other question. What other question they may ask? How you manage this question? So when they ask how you manage this question, then you should start after going for A to E assessment. I'd like to do NG, nasogastric tube. Okay, nothing per oral, NG tube for decompression, and then indwelling catheter, and start with IV fluid, and then go for medication, obviously PPI and antibiotic, analgesic, other related medication. And then the next is, before that, they may ask some investigation, related investigation. So split the investigation in 2 phases. So what are the 2 phases? The basic related investigation. So what are the basic related investigations? So for this examination, the basic related investigations are full blood count, electrolyte, LFT, CRP. Don't forget to mention blood culture and lactate. Okay. But a specific investigation, if you would like to mention the imaging test. What are the imaging tests step by step? The imaging tests are abdominal X-ray in erect posture, the first one. The second one is abdominal ultrasound. And then you can mention the CT, gastrography in enema, and if need, MRI after discussing with consultant. And you can do also endoscopy, colonoscopy if you want to mention the invasive test as well. These are the related investigation. And when you are going to manage this patient, don't go directly to surgery. So you mentioned that Hartmann procedure, isn't it? So
Yes,
Hartmann
sir.
procedure, everyone knows the Hartmann procedure, but the fact is, you'd like to start with conservative management, the antibiotic, analgesic, and other things. And if you fail, then go for radiological intervention. That is radiologically draining of this. If any abscess or collection, you can drain radiologically. And then if not managed, then you can go for Hartmann procedure with peritoneal toileting. Okay. And you can mention other things as well. So these are the complete things. Then they may ask, what are the basic difference for pulmonary embolism and anastomotic leak? How can you differentiate these two? Okay. So how can you differentiate the two? So when you start with ABG in A2E investigation bedside, then you will get respiratory alkalosis in case of pulmonary embolism, but there are no significant findings for except increased lactate. Just in ABG, you'll get some lactate in case of pulmonary, anastomotic leak. And ECG, there's some changes in case of pulmonary embolism. And in X-ray, you'll not find enough data from X-ray, but if you go for CTPA, there's a gold standard test, you'll get some findings. As well as when you are going for clinical examination, when you touch the legs, then there are some tenderness in case of P, but there's no findings in case of anastomotic leak. And the next is, if when you are going to check the drug chart and op chart, so the patient in case of op chart, raised temperature, raised total count in case of anastomotic leak, but heparin or warfarin missing in case of pulmonary embolism. And obviously history. History is acute abdomen and post-operative cases anastomotic leak, and long bone fracture is for pulmonary embolism. Do you have any confusion?